Hey, this is Nick Sinclair. This is another episode of Skin and Its Contents. I'm here with Dr. Wei Chen, professor of plastic surgery at Cleveland Clinic, world's expert in lymphedema surgery and super microsurgery. So thank you for joining us, Dr. Chen. Can you tell us a little bit about yourself and kind of how you got into plastic surgery and specifically super microsurgery?
Hello, everyone. I'm Wei Chen. I'm a plastic surgeon. So, how I got into microsurgery? Well, it started out when I was a medical student. I figured out initially I wanted to be a surgeon, and I got into general surgery. It was kind of a surgery undeclared. So, I explored my interest, and I fairly quickly found out that I gravitated towards precision oriented surgery. Initially, I thought it was cardiac surgery, then I transitioned to vascular surgery, and then finally I found my calling, microsurgery, and I found out that microsurgeons are plastic surgeons. So then I found out I had to be a plastic surgeon. And when I finally got in microsurgery, then this new subspecialty, super microsurgery, became a thing. So of course, my calling is precision surgery. So I had to become a super microsurgeon. So here I am.
Okay. And can you tell us a little bit, when we use the term super microsurgery, what exactly does that entail?
So we need to talk about microsurgery before we can explain what super microsurgery is. I think that in surgery, surgeons always work on having as good at hand control as possible, and that would include the ability to handle delicate structures. And as we develop our ability to handle smaller and smaller structure, and so does our ability to treat. And in the world of reconstruction, basically all major reconstruction involves microsurgery. Why? Because when we move tissues from a part of the body to another part, we need to reestablish blood supply. We need to reconnect arteries and veins and nerves, and these structures are small and therefore microsurgery. The formal definition of microsurgery is handling any structures, and most commonly arteries, veins, and nerves, smaller than 2 millimeters. Conventionally, microsurgery terminated at around low 1 and definitely in the upper end of the sub 1 millimeter range. And this was the case until super microsurgery came along. Super microsurgery starts where microsurgery ends. And that
Okay.
threshold is zero point 0.8 millimeters. And super microsurgery clearly has rapidly advanced just like medicine should. In its early inception, 2014 when super microsurgery was formally, this term was formally accepted at a consensus meeting slash statement. And at the time, back in 2014, it was defined as zero point 0.3 to zero point 0.8. So meaning the lower limit of human surgery was zero point 0.3 millimeters. As of today, we're down to zero point 0.1 millimeter or 100 micron.
I don't know if some of our guests, our viewers, our audience are able to really fathom or understand how small that is. Is there anything you can put that into perspective in relationship to that they may see or think about on their daily life?
There's probably, let's put it this way, when we operate, we need to use sutures. The sutures that we use in super microsurgery are smaller than hair. In
Okay.
fact, you can barely see them with naked eyes. And obviously, we don't want to lose anything during surgery, but if a super microsurgical needle is lost during surgery, don't fret. It's completely fine. It's way, way smaller than a surgical clip that frequently is routinely left. It's considered acceptable to leave surgical clips inside our body. They're designed to be used like that. So that probably gives people an idea. They're extremely small. This is as small as human surgery get. And getting small allows us to treat many conditions that were previously considered untreatable. And as we will discuss, that really has led us to the world of lymphatic medicine, lymphatic surgery, and also several brain disorders that we are now finding having great promise in being able to treat them.
Okay. When you first started performing super microsurgery and getting into these sub 0.8 millimeter vessels, what did that allow you to accomplish that traditional microsurgery didn't? What were the main problems initially that you were focused on with super microsurgery?
So, in my training, I've learned that the way to achieve proficiency is always to overtrain. So, if we want to be proficient in macro surgery, then training in microsurgery is key. And likewise, if we want to be proficient in microsurgery, then overtraining in microsurgery means getting trained in super microsurgery. So, for a super microsurgeon, expectedly microsurgery is not a daunting task. So after super microsurgery training, a 1 millimeter vessel, as we can imagine, big or small, easy or hard, these concepts are all relative. So
Hmm.
for macrovascular surgeon, 1 millimeter vessel is quite small, and 1 millimeter vessel is quite common in the digital vessels, the blood vessels in our fingers. So in a traumatic amputation, when we replant a finger, we need to reconnect these single millimeter, 1 millimeter vessel, which was considered a challenging task in the past for microsurgeon, even well-trained microsurgeon. But for super microsurgeons, 1 millimeter, we call that jumbo size. So everything is.
For sure. You've seen the field advance and move forward, and it still is moving forward. You touched upon it earlier, some of these previously untreatable diseases or diseases that have very limited treatment. So I believe a lot of your practice has moved away from more traditional oncologic or traumatic cancer reconstruction to lymphedema. So can you tell us a little bit about your involvement in the evolving field of lymphedema surgery, the medical management of lymphedema versus surgical management, and kind of your approach to lymphedema?
Yeah, early in my career, as a young microsurgeon, I wanted to help patient with all kinds of reconstructive situations. And I think it was very important for a reconstructive surgeon to have that experience. And but in terms of treating these patients who require various types of reconstructive microsurgery, very quickly I realized that lymphedema patients was the most underserved. In fact, they're so severely underserved that they would travel the world to find help. So the moment that patients found out, and patients from around the world found out that I offer lymphatic surgery, they sought me out. And very quickly, half of my practice became lymphatic surgery practice. And it just goes to show how underserved this patient population is. And so for a while, my department and institution, since at the time I was at a smaller department, we couldn't afford highly specialized that surgeons to have a narrow focus. So we kept my lymphedema practice at half of my practice, and I still perform. The other half of my practice was various other types of complex microsurgical reconstruction. And then when I came to Cleveland Clinic, thanks to our department, we have this opportunity to allow super specialization. And I think that's truly our strength, because for someone to be a true specialist focusing on a narrow topic 100%, the level of expertise is truly, I mean, that it's different. It's a higher level of focus and specialization, and we definitely have, in terms of technical breakthroughs, research breakthrough, we have benefited from that dedicated focus.
Hmm.
So how it became like that, it's, I think, mostly out of patient demand. There's truly a demand for lymphatic supramicrosurgical service, and also thanks to the capability of our department and here at Cleveland Clinic.
How does surgical approach and surgical treatment fit into the overall treatment paradigm for lymphedema? Is it the main modality now? Is it an adjunct to more lifestyle functional treatments, medical treatments? How do you see it fitting in with the rest of the treatment?
So on that front, the indication of surgery, how surgery fit into the spectrum of lymphedema care, that is rapidly changing. And my answer to you will likely be different if you ask me next year. But I can tell you that lymphatic surgery, this is really the fourth wave that reconstructive surgeons try to solve the problem of lymphedema. And the previous three waves have all failed. And this fourth wave, which really started in 1990 with Professor Hunchi Chan's development of lymph node transfer, so far has been working out very, very well. But even let's say 16 years ago, we were routinely telling patients surgery is second line treatment,
Hmm.
and we would want patient to have attempted lymphedema therapy and having failed lymphedema therapy before we consider surgery. And I think considering the level of surgical development back then, it was reasonable because we didn't want to overpromise. Surgery is invasive, so it should be second line. But it's very different today. Surgery, in the experience, in the hands of experienced surgeons, we can expect consistent, highly reliable results, and we also know that early diagnosis, early intervention, including surgery, frequently lead to the best result. A prime example would be the prevention surgery. If we intervene early at the time of lymphatic injury during cancer treatment, then we have a good chance of aborting the whole lymphedema disease process altogether or cure. So that would be a prime example of really early intervention leading to the best result possible, cure. So as of today, surgery definitely plays a key role in lymphedema care. I consider surgery and all the non-surgical treatment modalities of lymphedema as equal but different treatment options with their pros and cons. And so a patient with lymphedema should be presented with all of these treatment options, and the treatment should tailor to individual patient.
Okay. What do you think at this point for the patients that are suffering from lymphedema? What are the biggest hurdles that they face in terms of understanding their options, as you mentioned, receiving all the viable options, the best information out there, making an informed decision?
So I think the biggest hurdles, I should start with what's so painful about having lymphedema. I think physical symptoms is one thing. Physical symptoms obviously presents physical suffering, but there's a lot of emotional suffering with lymphedema, and that comes from a feeling of helplessness. And that brings us to the two major hurdles of lymphedema care. One is this exclusivity of lymphedema expertise. There are so few lymphedema providers, whether it's surgical or non-surgical. So frequently patients need to travel long distance, out of state or international to seek proper care. So that generates a lot of helplessness. There's a lot of wrongful false reassurance from many providers telling the patient it's some benign swelling, just wear compression, you'll be fine. Patients themselves know it's not fine. And this inability or hardship to find appropriate care is the first problem. And the second obstacle is completely related, actually results in the first problem that we talked about, which is this difficulty in obtaining insurance coverage for the care, for lymphedema care. And this difficulty with insurance coverage leads to lymphedema care not being viewed favorably by many medical establishments and
Mm.
institutions. And that results in inability, even if the institution want to help out lymphedema patient, they can't just provide service without being paid. So that results in many services being not sustainable. So these are the two major issues. Number one, few providers, and number two, poor insurance coverage or
Okay.
difficult insurance coverage.
And obviously, I think you are helping to combat the first problem by establishing yourself as an expert. And obviously, you have a large role in teaching here at Cleveland Clinic and internationally. But the insurance coverage one is sometimes beyond our scope as single physicians or surgeons to really move the needle. So that one is a little bit more difficult to tackle.
So for us at Cleveland Clinic, we have run into lots of challenges, but I think exactly because of who we are, we have certain leverage. We especially should be helping these patients because if we have trouble getting insurance coverage, you can imagine smaller institutions or
Hmm.
individual providers, what kind of difficulty they will be facing. And that's why I think what we're doing here is important.
Excellent. And you mentioned if I ask you in a year, your answer will be different to kind of how surgery fits into the lymphedema treatment paradigm. What are the major changes that you see on the horizon in terms of new indications for surgery, new techniques? How do we move the field, or how are you moving the field forward?
So I said by next year, my answer would be somewhat different, is because surgical treatment is rapidly advancing, improving. In fact, for all of our patients, when we get to the surgical consent portion, when we talk about risk benefits, I always explain one of the risks of surgery is today we're offering you our best, but tomorrow we're likely to have something better. It's just like your iPhone. Every year you expect your next iPhone 18 next year, to be better. Sometimes only minor improvement, but every now and then there's a major breakthrough. And because the surgical outcome, surgical treatment has been rapidly improving. And actually, last month I explained to a colleague, I was giving a lecture and I said, what we consider phenomenal result 15 years ago, today it's the norm. This is our typical result. And what we consider a good result today, we could only dream of back in the day. So we're rapidly advancing. And this has certainly led us to areas that we have not imagined in the past. One key discovery is that lymphatics is involved in nearly all organ systems that we know of. So lymphatics is the garbage disposal for all of our organ system. It removes the waste material. And this goes for not just arms and legs. Goes for all the internal viscera, our liver, our gut, and most importantly, our brain. And there are many conditions affecting these organs that currently are going by different names that are actually a lymphatic problem. Or at least now we have found out that lymphatic dysfunction plays a role in these diseases. So that's what I meant. And it's certainly very exciting as we move forward, finding out one by one that many of these conditions previously considered untreatable, now that we know that lymphatics plays a role in their pathogenesis, and nothing has been done about it. Now we have an angle to
I know you touched on it earlier as well, and I don't want to put uh, the cart before the horse, as they say. But some of these, and you just mentioned again, maybe in terms of diseases of the brain, neurodegenerative diseases, without being overly ambitious, how do you see lymphedema surgery, supramicrosurgery fitting into some of these neurodegenerative diseases? Do you see a role for it potentially?
So that's certainly one of the most significant, exciting progress that we've made. It's actually not so recent, but there has been multiple breakthroughs. But since this is a public podcast and there are certainly unpublished materials, so I'll need to dial down our excitement and keep everything very matter of fact and very factual. It's fair and safe to say that there is a tremendous correlation between lymphatics and brain health. um, Even from day one when I started to treat lymphedema, and this is back in early 2000, well, in the beginning of 2010, that I observed in many lymphedema patients, they demonstrated Alzheimer-like symptoms. They have dementia-like symptoms. They had impaired cognition. And what was interesting was following treatment of their lymphedema, we operated on their legs and arms. And then they told me, yes, my swelling went away, but so was my attention deficit,
Hmm.
and so was my brain fog. So that was what initially led us to the discovery of this correlation that lymphatic health plays a role, certainly affects our cognition. And then combining with Michael Niedergard's discovery of lymphatics in 2012, and our very own Dr. Antoine Laveau out of our Learners Institute discovery of meningeal lymphatics in 2015, everything clicked. We then came up with the hypothesis, and I'm sparing you a series of discoveries because it would take too long to go through them, that led us to the hypothesis that we can treat dementia, since there's definitely reason to hypothesize that at least a portion, and at this time we don't know what percentage of dementia, Alzheimer's, Parkinson's diseases are lymphedema of the brain, but it's fair to say that brain lymphatic dysfunction plays a role. And we know how to treat lymphedema. Our surgery is effective in treating lymphedema, and therefore we may be able to treat these brain disorders. So we initially put this hypothesis together, and we designed a surgical procedure to treat brain lymphatic disorders. By now, 10 years ago, it was 2016. And you can imagine, if you are finding what I just said shocking, you can imagine how shocking or unacceptable this was 10 years ago. And of course, it was impossible to secure an IRB for us to move forward with this surgery. Fast forward 10 years, as of today, such surgery has already successfully happened, and a good number of them in Asia. And here at Cleveland Clinic, we've also started our investigation.
It's exciting stuff. I'm sure some of our viewers are probably, particularly interested in it. I think a lot to be seen still. It's the kind of the emerging front. So I appreciate you keeping it factual on that front. But it's exciting to see. Any other major things you're excited about in the field or adjacent parts of plastic surgery?
So uh, there's quite a bit. Of course, a microsurgeon, super microsurgeon, I will tell you what from my angle. There are many exciting frontiers. One frontier is, as I've mentioned, we're just now finding out lymphatics playing a role in so many diseases that we previously are calling these diseases something else. They're actually lymphedema, and we may be able to treat them. I've just given you the example of brain. And by the way, I mentioned Alzheimer's and Parkinson's, but it is actually a laundry list of brain disorders. And if you're interested, please stay tuned. We have studies coming out. And you've heard me mentioning liver. There are certainly conditions of internal viscera that we're now working on potentially being able to treat, because now we found out that these conditions are very likely lymphedema of the liver, lymphedema of the bowel, and they are currently going by something else. And if you think about how we're treating them, how there are very limited treatment options, it's actually not surprising why that is, because in medicine, we know if the diagnosis is off, the treatments won't be effective. So yes, that's another frontier. There are several conditions that we are working on that we may be able to treat, just like the brain lymphatic disorders. Another frontier that's rapidly evolving is the robotics. The robotics, as of today, we are incorporating the use of robots in all of our advanced microsurgery and super microsurgical procedures. I think robots has tremendous potential, as I think most people can imagine. The capacity of robot is particularly worthwhile in these extremely delicate procedures. For human, it may take decades of training to achieve that level of technical finesse, but with robot can just do it. So robot also allows us the potential of getting into places that are difficult to get to. Currently, our surgical proposal to treat Alzheimer's and Parkinson's disease are extracranial, but we are already preparing for the possibility and the need for getting into the brain. We may need to get directly into the head and working on the brain. If that were the case, of course, we can go with the conventional neurosurgical route of opening the skull, accessing the brain, but it would be obviously better if we can just create a small opening in the skull and accessing the brain with robotic arm. So robot, that's another exciting frontier, which we're also actively, rigorously investigating.
All right. Yeah, I think to your point, step one is diagnose. You have to have a diagnosis to have an adequate treatment. And for many of these conditions, either we don't know what the diagnosis is, or many physicians are not trained on how to diagnose, particularly with things like lymphedema. Before we finish up, any final things that you want to mention? If we do have potentially patients that are suffering from some of these conditions, anything you want to say directly to them to kind of how they can navigate the architecture, the landscape of care and kind of being their own advocate and their own researcher?
But I think what we can, an important message that we can take this opportunity to deliver to people is that lymphedema is quite treatable. And as of today, we just talked about a lot of advanced, cutting edge investigational concepts and procedures. We can get back to the ground now about standard lymphedema care. As of today, well, it by itself tells a lot. When I say lymphatic surgery for arms and legs, this is what I consider now fairly mature. We're delivering consistent, predictable success. So lymphedema patients don't need to feel helpless. There are effective treatments available. The expertise is, as of today, still exclusive, but help is available, and we are working on disseminating the expertise with our training program. So with time, I do expect that situation will get better. But as of today, I think it's important for lymphedema patients to know effective treatments is already available, and lymphedema surgery is now considered, from our standpoint, sufficiently mature.
All right. Excellent. It's nice to be able to offer a treatment that consistently delivers results. And I appreciate all the work that you have done in this field, that you continue to do, and it's exciting to watch. I'm a little bit on the sideline in a different field of plastic surgery watching, but I'm cheering you guys on because um, these are big problems that have been, as you mentioned previously, untreatable, and so it's very exciting thing to see. Thank you for joining us. I appreciate all your wisdom, and we'd love to have you back on maybe next year, and we can see where we've come and how the conversation is different a year from now.
It'll be my pleasure.
All right. Thank you.
All right. Thank you.